Optimal duration of dual antiplatelet therapies. Important for you to note my disclosures, specifically the fact that I'm leading the trial of Twilight, which I will be mentioning. When we talk about optimal duration of dual antiplatelet therapy, it's all relative. And my friend Roberto told me whenever they ask you what is optimal this or whatever the question is, the answer always is, it depends. And it depends is the real answer. Do you like that, Roberto? That was for you. So the optimal duration and what is that required, to me, the most important question is, what is that required duration for which a patient needs to be on dual antiplatelet therapies after you put in a drug-eluting stent? And I think that important mandatory period has not yet been completely evaluated. But the biggest important thing is, as us for clinicians, is to say, when can I safely take this patient off of a dual antiplatelet therapy if I put in a drug-eluting stent? And then beyond that, that's a stent-related issue. Beyond that, it's about the patient. And it's about the patient's risk profile and understanding how best to improve their outcomes. And that, to me, is when we start making decisions about the possible, giving the patient possible prolonged dual antiplatelet therapies. But does one size fit all? And the answer is no. Unfortunately, it's not one of those things of the everybody's can go into a formula, or thank goodness for that, because we as clinicians have to take into the ischemic risk, the bleeding risk, and we actually have to evaluate the patient's clinical status, which includes a slew of things, including their socioeconomic status, their expected adherence, their behavior in understanding their disease process and wanting to comply with your prescription. So let's just go through some of this, and I'm going to go through as fast as I can. And we start with clopidogrel. How did we get there? We got there from this trial that is the only trial and will never be repeated of clopidogrel versus aspirin in reducing in patients with recent stroke MI or symptomatic PAD, the Caprice study, looking at vascular death MI and stroke, showing an important reduction when you compare placebo to aspirin to clopidogrel, and you see what an important reduction you have from placebo to clopidogrel and even from placebo to aspirin. So we really introduced clopidogrel here, and very importantly in patients with acute coronary syndromes, showing that dual antiplatelet therapies instead of single with just aspirin alone had a very important reduction in death MI and stroke in patients, especially those who underwent PCI. And this wasn't just in the first 30 days or 3 months or 6 months, but it was actually beyond that up to a year. And it is for this study that we are now prescribing dual antiplatelet therapies for a duration of 12 months in patients with acute coronary syndromes. It has absolutely nothing to do with the stent that you're doing, with what procedure you're doing. It's with the presentation of a patient with an acute coronary syndrome, and it comes from this trial. And we are all very worried about stent thrombosis, especially in the first era of drug-eluting stents, and whether or not our patients are going to get off these dual antiplatelet therapies. It was this important study by Antonio Colombo and group that showed, for the first time, I never saw hazard ratios of 161 times higher rate of having a premature disruption or discontinuation of your dual antiplatelet therapies and its association with stent thrombosis, which was a very, very detrimental event. And in fact, in the early days, we were seeing these curves going up and up and up with no flattening of these curves, stent thrombosis on the rise, and basically going all the way with the first generation drug-eluting stents. And of course we're worried about stent thrombosis. Of course we want to protect our patients against them, but we must be worried also about the price we would pay when we put these patients on prolonged dual antiplatelet therapies. And bleeding awareness, I can attest to the fact that I'm responsible for this, a lot of this, for the last decade. I've spent my life thinking about this, but very important, and the credit should go to our McMaster University group, where John Eichelboom for the first time showed that look at how important bleeding events have to do with subsequent death, and that if a patient has a major bleeding event or a life-threatening event, they're going to have a much, much higher rate of death down the line. And beyond that, we took that onto consideration into looking at the acuity study, looking at which one is more important, a myocardial infarction that we're trying to reduce by giving anticoagulants and antithrombotic regimens, or the bleeding that we're going to cause the patient. And what we found is that both are extremely important, but myocardial infarction is very important early on as an important hazard, but bleeding is a gift that keeps on giving, that no matter when you have the bleed, you are going to have a very poor outcome for those patients, and the hazard doesn't go away, it stays on the wrong side of the equation all the way through, whether you have it early or late. And where we are today is in this equipoise time. We now know that while we were very worried about the early generation drug-eluting stents and those SCAR registry numbers with the curves going upwards, we now know that we have better stents, and we continue to improve our drug-eluting stent technologies. We spent the entire morning talking about them, and while the network meta-analyses should only be hypothesis generating, but more and more data are coming in showing that the cobalt chromium everolimus eluting stent and the next generation DES is absolutely better than the first generation, and in fact maybe even better than the bare metal stents that we are so excited about early on. And then comes the DAPT study. The DAPT study threw us all out of the corner. This was a huge study, 10,000 patients who underwent PCI with a drug-eluting stent, and they passed the stress test of 1 whole year of dual antiplatelet therapies with absolutely no ischemic or bleeding events. And they came to their doctor exactly when you would see them and say, do I continue or do I stop the dual antiplatelet therapy and go back to aspirin? And these very smart investigators from Harvard, what they did is they said at 12 months, those event-free patients now will be randomized to thienopyridine plus aspirin or placebo plus aspirin in a double-blind placebo-controlled fashion. At the end of the 30 months, they observed them off the study drug to see what happens to them. There were 2 co-primary endpoints. Their hypothesis was that if you give them a prolonged dual antiplatelet therapies, you should get rid of stent thrombosis and perhaps all those important ischemic events. And of course, they met both of those co-primary endpoints. They reduced stent thrombosis by 70% by giving the patients 30 months of dual antiplatelet therapies. And they also reduced major adverse cardiovascular and cerebrovascular events. So they met the primary endpoints. And at that point, it was like, wow, we're going to have to give dual antiplatelet therapies to everybody. But I always say, always read between the lines. If this is so good, why is mortality going in the wrong direction? A lot of this was driven by myocardial infarction. What is happening in this study? And it was very, very important to look at the myocardial infarction. Is this about the stent or is it about the patient? And in fact, over half, 55% of these myocardial infarctions had nothing to do with the stent. It was about the patient and their milieu and what was happening outside of the stent that was being prevented by dual antiplatelet therapies. And very, very important is the fact that the price that was paid for reduction of these ischemic events was not small. These were important moderate to severe gusto bleeding, which was significantly higher. And in fact, this was also seen in the BARC type 2 and type 3 bleeds significantly higher. And again, mortality went in the wrong direction. And remember, I just told you that our stents are better, and close to more than half of the patients had first generation DES. And so was this being driven by the fact that these were first-generation DES patients, especially when we see all-cause mortality going in the complete wrong direction. Well, many people, including us, and of course I'm going to show you our meta-analysis, but there are many, many meta-analyses of DAPT duration after DES. And what we showed in the meta-analysis by Justino that was published in JACC last year, including the DAPT study, tells you that a longer duration of DAPT is associated with a lower stent thrombosis and a lower myocardial infarction. Of course, you give somebody a potent antiplatelet, you are going to reduce thrombotic events. And that is exactly what happened in the DAPT study and in this meta-analysis. What we did find, though, that if you shorten the duration of DAPT, you could reduce bleeding. Of course, that is something you would expect. You don't give them dual antiplatelet therapies, you're going to reduce bleeding. But guess what? Mortality also went in that direction of reducing. So what's a clinician to do? It's a very, very difficult place to be. And who would benefit from prolonged DAPT? We need to know who these patients are because we don't want to ration and be scared of bleeding and then lose the patients who might benefit from prolonged DAPT. Well, we have some idea from Deepak Bhatt's study of the Charisma study that he led with Clopidogrel, where he saw that although the primary endpoint of that study was negative, but there was benefit in patients with secondary prevention in high atherothrombotic risk, prior MI, stroke, peripheral vascular disease, or prior CAD. There was a reduction overall in that group of patients. And then this was repeated experiment with a more potent agent, ticagrelor, at 2 different doses in the Pegasus study at 60 milligrams BID versus 90 milligrams BID versus placebo on top of aspirin in patients with prior myocardial infarction and also other risk factors such as diabetes, or these were stable patients, but they did have multiple risk factors. The primary endpoint was positive in favor of the potent agent ticagrelor on top of aspirin in preventing this important cardiovascular death, myocardial infarction, and stroke over time. They studied 22,000 patients to show this benefit, and there was a very important outcome that all of the ischemic sub-endpoints of the composite, the members of the composite endpoint of death, myocardial infarction, and stroke, thank goodness, fell in the right direction for this more potent agent. And in fact, it was seen at both doses, the 60 and the 90 milligrams, had a much better effect on all of the ischemic endpoints. But there was an important bleeding price to be paid, almost as much as the ischemic benefit, you paid a price in bleeding. So the big question was, where do we find the best patients to give this important therapy to? So after all of this, for the very, very first time, the task force of the ACC-AHA got together, led by Glenn Levine, in an incredible first ever focused update on dual antiplatelet therapies in patients with cardiovascular disease. They basically got together not just the PCI writing committees, but also ACS, STEMI, as well as the CABG. And what they did is they asked these critical questions to the members. And I was fortunate enough to be part of this. And what was great about this is that while the members were to study and look at the evidence, the true evidence was actually reviewed by an evidence review committee. And it was asked of them 3 questions. In patients treated with newer generation DES, and whether it's for ischemic heart disease or acute coronary syndromes, compared with 12 months of DAPT, can we go shorter to 3 and to 6 months of DAPT? So very, very important question. Number 2 was in patients who were treated with the newer generation DES compared to 12 months, can we go higher? Does 12 to 18 months of DAPT result in reduction of mortality and these important endpoints without, and does it decrease stent thrombosis and or increase bleeding? Important question. All of those are big, big questions for us as clinicians to set our guidelines to. And then, very important, the Pegasus question in post-MI patients, STEMI or non-STEMI, who are clinically stable and they're 12 months out of their MI, should we be giving them more DAPT to reduce their major adverse events? This evidence review committee, who did not have any conflicts of interest, reviewed this report. What they came up with quickly is that 5 randomized clinical trials in elective DES showed that most likely and a shorter duration of DAPT resulted in less bleeding, and it did not have an increased risk of stent thrombosis. Number 2, with the longer duration, what they found that there were 6 randomized clinical studies. Taken as a whole, the studies of longer duration, prolonged or extended DAPT for an additional 18 to 36 months found these important benefits. 1 to 2% absolute decrease in stent thrombosis and ischemic complications, and a 1% increase in bleeding complications. And this weighted benefits basically shows, 6 fewer MIs if you treat 1,000 patients, 3 fewer stent thromboses, and 5 additional major bleeds. And then lastly, they wanted to understand, what do you do for the prolonged, greater than 1 year? And what they said, that the risk-benefit is pretty much equal. So as much as you reduce ischemic events, you also increase bleeding. And so the master, I think, algorithm that you will now find in the current guidelines is as following. Here's a patient with coronary artery disease. What you need to do is to say, are they stable or do they have an acute coronary syndrome? Very, very easy. If they have an acute coronary syndrome, the class 1 indication is 12 months. Beyond 12 months, it's class 2B. You make a consideration. On ischemic, in stable ischemic heart disease, if the patient undergoes PCI and receives a DES of the current generation available, we reduce that now to 6 months instead of 12 months mandatory. And of course, in post-CABG, it's class 2B for the duration. And so these are listed here. Please go ahead and read those. And I just want to quickly tell you what's the future. The future now is in better understanding how best to choose the best patient, and can we withdraw some of these therapies. The fact is that we now have aspirin as sort of the baseline treatment for pretty much everybody. And the data is extremely limited after PCI in preventing the very, very important complications that we're looking for. But we do know that aspirin is a great slougher of the GI tract, and it can cause a lot of bleeding. In fact, the global leaders, investigators, have randomized 16,000 patients with PCI with their biolumis-eluting stent, and they are only these patients, after a month of aspirin and ticagrelor in this experimental arm, are getting off of aspirin and on ticagrelor alone versus standard of care. All patients have been randomized. We're in the follow-up phase, and the trial is continuing. The DSMB has not stopped the trial. And we, here at Mount Sinai, have undertaken a very, very big trial, the Twilight study. 9,000 patients after complex PCI will receive aspirin and ticagrelor for 3 months. And then at 3 months, they will get randomized to placebo plus ticagrelor versus aspirin plus ticagrelor. We've already enrolled over 1,200 patients, and for all of you out there who are investigators in this trial, thank you for all that you are doing. Lastly, it's all about you, the doctor, balancing the risk of bleeding and ischemic complications. How do you do this? You actually have to talk to the patient and examine the patient. But if you're not up to that, there are scores out there and apps. And the DAPT score is one of them, and there's an app in the Apple Store that you could download on your smartphone that will give you a great risk if a patient after a year who passed their first year of stress test of aspirin and dual antiplatelet therapies, and now you don't know what to do, you can put in their risk score and they would give you a great risk for their ischemic risk. I could tell you that if the DAPT score is high, these patients, you could see, only need 34 patients, numbers needed to treat to prevent ischemia for prolonged dual antiplatelet therapies. That's at about a year. What we have developed is a Paris risk score, which was just published in JACC, at the time of PCI, where you will evaluate the bleeding risk and the ischemic risk in the same patient, because guess what? A lot of this overlaps. And what you need to do is to get a risk that says, here's your ischemic and bleeding risk in the same patient. And in here, you're able to plot this and figure out where your patient fits for whether there's benefit or harm in prolonging dual antiplatelet therapies. So finally, in conclusions, so it was very hard to put together the guidelines, but remember, the guidelines are just guidelines. You as a clinician gets to make a decision. But there's no question that a longer dual antiplatelet therapy after DES is associated with protection against ischemic events. But it also increases the risk of bleeding and possibly even all-cause mortality if you're not going to be careful. Spontaneous bleeding events are not small events. They're extremely important. A patient bleeding out in a GI or a GU tract after a DES could have a much, much bigger and an important detrimental event than a patient who just has a small troponin increase. So it's very, very important to think about that. And very important is that our next generation DES have really improved a lot of the stent-related complications, but we still have to figure out about the patient. So prolongation of that mandatory period of DAPT will protect you against non-stent-related complications, and it's important to note that, those thrombotic events, and you have to do this in a judicious and a careful fashion. So the optimal duration of DAPT depends, as I said in the beginning. Obviously, the shorter the better. Longer is not always better. You really don't want to be exposing and telling them that their mandatory period is long. You want it to be short. You want to be able to stop the therapy, but you really should be thinking about the risk of bleeding and ischemic risk in a patient in front of you, sitting right there, and please talk to your patient and make those evaluations. Thank you so much for your attention.